This is our disclosure policy, and this is Dr. Thumala's topic for presentation. Dr. Thumala, do you want me to launch the pre-test questions right now?
I think that'll be great. Good morning, everyone, and thank you for allowing me to present today. I was asked to talk about long-term effects of chemotherapy. I was expecting a case or two, but let's move on to some of the questions I have posed for the audience. And then as we dive into the lecture, I will explain what those questions are and give the answers away. So the first question was chemotherapy is used for the treatment of breast cancer and can be associated with risk of cardiac toxicity. So what percentage of patients develop cardiac issues post-treatment? And here are your choices between A, B, C, and D. So mark it out, and through the lecture, I will go over the answer to that question. The second question here was following is the most common long-term effect of the use of anti-estrogen therapy in the treatment of hormone-positive breast cancer. A is psychological effects, vaginal dryness, loss of bone density. Sneha, can you advance the next question?
Can you see it?
I really can't see the third and fourth question.
Is everybody else able to see it?
Yes, I think we just have to scroll through on our own. It's a separate poll on everybody's.
All right, there you go. All right, got it. So I thought she was controlling the scroll. So anyway, the third question was the risks for second cancers like solid tumors, hematological malignancies, breast cancer in patients with mantle cell radiation. The following tumors are usually seen in patients who have mantle cell radiation. A is gastric cancer, B is lung cancer, third one is breast cancer, and the fourth one is Hodgkin's lymphoma. And the fourth question was about receiving immunotherapy with near complete response to treatment in a patient who develops severe colitis requiring hospitalization. What's the usual recommendation for patients who develop severe colitis with immunotherapy? Antidiarrheal therapy and continue treatment, dose reduce the immunotherapy, discontinue treatment permanently, or drug-free holiday and resume therapy at the same dose. And the last question was in a patients with, I'm sorry, we have two questions. I thought you got the last question. The fifth question was about patients with head and neck cancer who are treated with cisplatin and radiation as standard of care. After 2 years, this patient presents with dental caries and chronic dry mouth, and patient was unable to hear or understand most of the questions during the conversation. So what part of his history is relevant to explain the above findings? History of head and neck cancer, radiation therapy, cisplatin therapy, or cisplatin and radiation therapy. And number 6, the last question is on long-term survivors of Hodgkin's lymphoma or allogeneic transplant. How long should they be followed with either an oncologist or a primary care provider? The choices are 5 years, 10 years, 1 to 3 years, and lifetime. All right. So with that, we'll dive into the lecture.
Let's just give it another 5-10 seconds more, Dr. Thumala. We're just right there. About 8 people have answered. I'm tempted to give them another 10 more seconds.
Definitely.
Good questions, Dr. Thumala.
Well, I'm going to ask you guys once I finish. I can call on anyone, right?
Oh, no.
I know which ones Dr. Goldberg and Dr. Bainers are going to get, so I won't pick on them.
Okay, so I'm ending poll now, and we will come back to this later.
All right. Can I start, Sneha?
Yes, you can.
All right. So I think I was asked to talk about long-term and late effects of cancer treatments. And, given the volume of oncology, I'm not too sure if I can do justice in just this 30 minutes about including all cancer treatments or all the treatment we use on different types of tumors. So I did my best to pick and choose some of the oncology groups so that we can have some form of discussion for survivorship. I'm going to talk a little bit about the current best practices and recommendations for survivorship and how we coordinate our care between rural providers and stay up to date with the current recommendations. And I think the key for survivorship is definitely the communication between the oncologists and the providers who are caring for these cancer patients. So next slide. So this is our complex world we live in. And when I was training about 16 years ago, the simplest form of therapies were surgery, radiation, and chemotherapy, and that's all we had. And for once the surgical part is out on cancer patients, their radiation is more a localized form of therapy. And we heard that from the lecture 2 weeks ago about the types of radiation. But then enters the complex world of what we do as oncologists, because it's just not chemotherapy now. We are moving into the field of immunotherapy, targeted therapy, hormonal therapy, and stem cell therapy, transplant. So chemotherapy are specifically devised to attack the cancer cells, but in the process, they have very toxic effects on even normal tissues. Whereas if you look at immunotherapy, these are good. The good part of it is they use your own immune system to kick the tumors, the T cells, to attack the cancer cells. But in the process, they can overactivate your own immune system. As a result, you can develop some toxicities related to that. Targeted therapy, this is the whole field we are swimming in as oncologists now. This is what we call as next generation sequencing testing. We are looking at particular molecular targets on the cancer cell where we can use a drug to attack that particular molecular target, and that causes the cancer kill. So basically what we are really doing is diving into understanding what a cancer cell does and what a cancer cell behaves, and then using therapy to how to kill the cancer cell. So it's really a fast and a very expanding field nowadays. And honestly, there are 300 new drugs in the pipeline in every month, and it's really wealth of information for us to keep up as oncologists. Hormonal therapy, this is what we have tested in the process of breast treatments of breast cancer, prostate cancer, and we already know this has been around for a very long time. And of course, bone marrow transplant for leukemias, lymphomas. Next slide. So I do take care of a wealth of breast cancer patients, and traditionally these are the therapies which are being the gold standard for management of any cancer, any patient coming in with breast cancer. So you have the surgery where the choices are between taking part of the breast out versus mastectomy, the whole complete breast, and also different modalities of breast reconstruction. We heard from Dr. Benos and Dr. Goldberg. Then comes in my role as whether I have to decide whether the patient requires chemotherapy or whether the patient requires targeted therapy. So we do look at estrogen, progesterone, and HER2/neu as three main receptors to decide what form of therapy the patient with breast cancer gets. So the targeted therapies are those which are devised directly to attack the HER2 positive breast cancer, and this is seen in about 20 to 30% of all comers with breast cancer. And anti-estrogen therapy is typically reserved for those patients who are estrogen and progesterone positive. Again, those who are expressing negative estrogen and progesterone on their tumors do not benefit from an anti-estrogen therapy. Radiation is a very localized form of therapy for management of these patients. Next slide. So I won't dive into all the treatment options we have for breast cancer because that's a lecture by itself. But so when I won't talk much about the surgical complications, but just to briefly touch on The breast surgery can be complicated by either accumulation of fluid in that area, which is seromas, or where the fat necrosis. This is like a very common finding I see in patients who have surgery or radiation, where they have this pain, chronic pain in their breast, and that lasts for a long time. And unfortunately, fat necrosis is where death of the fat causes abnormalities in your mammogram and MRI for interpretation, sometimes leaves a big fat lump in the breast. Patients always feel they never got rid of their cancer. They can have acute effects where they can have infections in that area, but I have seen cellulitis of the breast even in long-term survivors. And lymphedema is a complication where there is a swelling of the arm as a result of either radiation to the armpit axilla or to the chest wall area. This is also from taking out too many lymph nodes from the axillary area. Radiation has its own effects on the chest wall, and we heard that last 2 weeks ago. And nerve injury, I have seen some patients complain of arm pain and that dragging sensation in that arm where they had the surgery. And sometimes because of the nerve injury, it leaves them with long-term paresthesias or tingling numbness. They don't feel the area, and they have persistent pain in the chest wall. Next slide. So the rib fractures, which are associated with radiation, are pretty rare. Again, osteoporosis also remains a significant risk factor here, but I did see that in about 2 to 3% of my patient population. So overall, it's pretty rare. Again, if you have a fracture, always look for, is this cancer related, or this is just an osteoporotic or post-traumatic, post-treatment related. Brachial plexopathy is the same nerve pain which I've been describing, where the brachial plexus, the nerves which run down the arm, are affected, and that causes tingling and numbness and weakness in this arm. Again, seen but not a very common complication. Next slide. So this is what I do. This is more of the systemic therapy in management of breast cancer. So we use a multitude of chemotherapy drugs, but the most important ones we worry about are anthracyclines. That's your red devil, or the adriamycin, or the doxorubicin. So we worry about something called cardiac toxicity in these patients. So the risk of just cardiac dysfunction and in patients is anywhere from 6 to 11%, but it increases and it's very cumulative in elderly women. So we tend to avoid some of these drugs in women who are over 65 or have other comorbid status. So if you use anthracycline alone without any other targeted therapies like HER2 therapy, the pertuzumab, trastuzumab, because it's interesting that breast cancer cells which express HER2/neu also have HER2/neu receptors on the cardiac tissue. And that is the reason we worry about so much of cardiac dysfunction in these patients. So if you combine the anthracyclines, the pertuzumab and the trastuzumab, your risk honestly increases up to like 20%. So monitoring the ejection fraction, monitoring the cardiac symptoms in these patients becomes extremely important. The good news is the cardiac dysfunction with pertuzumab, trastuzumab is not long lasting. When you withdraw your medication, most of them correct back to the normal stage. But cardiomyopathy, which is enlargement of the heart associated with anthracyclines, can leave long lasting cardiac dysfunction. So we have to be very careful of how we screen these patients for that. Next slide. So the other part of therapy which we use in breast cancer is what we call as endocrine therapy. And this is in patients who are estrogen and progesterone positive tumors. These are the tumors which are expressing these receptors. And we use anti-estrogen therapies. There are different forms of anti-estrogen therapies. The selective estrogen receptor modulators or aromatase inhibitors, which inhibit the aromatase enzyme. The tamoxifen is more a drug reserved for premenopausal women. And this has been like, probably even from the times before I was born that we've been using tamoxifen. And finally, we got some results on the meta-analysis, which looked at about 7 adjuvant trials. I mean, it's very, very difficult to do an adjuvant trial in breast cancer because you have to have a follow-up of more than 10 years to even see a difference in the treatment. So after studying about nearly 20,000 patients on these estrogen therapies, the risk of cardiac toxicity and other cardiovascular events is with a relative risk of 1.3. So it is small compared to the population we treat, but we have to talk about it. And then, interestingly, tamoxifen has some pro-estrogen effects in women rather than a complete anti-estrogen effect like the aromatase inhibitor. So it has some protective effect on the heart as well as in your cholesterol profile. So it's preferable. So we have to make these choices when we screen our patients of what comorbids they have and how much gain mileage I'm having. Suppose the cancer is a really high risk, then you can push your limit on envelope on some of these side effects. But if we have a choice, we want to like to switch it to something which is less toxic. Next slide. Now, rarely we do see what we call as secondary tumors in management of these patients. Now, interestingly, when I was doing fellowship or residency, the lifespan of most of these women was very short. But now with the advent of these new therapies, I have patients whom I'm following for the last 16 years, and it's almost like at 10 years, I would say, okay, you're done with your treatment. You can follow up with provider, but they just kind of hang on with you. And when you see them the longer time, then you do see some changes in either their bone marrow function because of the pre-existing chemotherapy, radiation, and that's why screening these patients for secondary cancers as well as for acute leukemia myelodysplasia is becoming an issue now. And again, previously the lifespan was so small, and whatever numbers I quoted there, which being less than 1%, I think is probably much more than that because of all other confounding factors which we are seeing. So I have so far in 16 years of my practice, I would say I probably have 5 patients with myelodysplasia, and we just diagnosed another patient with leukemia. So it's not unusual that you see. And that's when you really feel that you're so old in this profession, when you start seeing leukemias and myelodysplasias. So next slide. Other effects, these are the most common ones, and this is where my time really is spent on managing these patients. It's the menopausal symptoms. So they're really not happy with the first part of the session is all about taking care of the breast cancer. Will I survive? And once they survive, it's all about the menopausal symptoms, which the women usually care about. And I think it's important. It's important, especially like dealing with hot flashes, dealing with vaginal dryness, dealing with vaginal atrophy has a major impact in their sexual function and fertility options. They also have hot flashes which interfere with their quality of life. This is more pronounced with all those anti-aromatase inhibitor drugs which we use. Women who are very young and premenopausal do develop something called ovarian failure, where we give chemotherapy and they completely have shut down of their periods. And most of these women gain back that ovarian function, although we oncologists don't like it because of the estrogenic influence. But it is premature menopause, and that can be a big time life-changing event for them. The way we manage these is really no different from our general population, except remember that in breast cancer patients, you want to stay away from the hormonal manipulation to control these. So we have to use additional drugs which have additional toxicities. Next slide. And chemobrain. Chemobrain is one thing which is either it is overused or underused, or it sometimes gets ignored. I would say that I think most of the patients who are on chemotherapy have some form of lapses of memory. I think it's just a confounding factor of so many events which are going on these with patients. So dealing with the side effects of chemo, with the financial toxicity, the stress of coming in, the transportation, social events, and all of that, and plus dealing with the side effects of chemo, I think is just a co-factor. But it's related to chemotherapy in nearly 60% of patients who develop, and they can be acute, where they're only during the treatment of chemo. So it's a little reassuring to tell the patients that with passage of time that you will get better, and most of these symptoms actually stabilize. But the older the patients are, it leaves a permanent more of those cognitive dysfunctions. And I do notice that as we go along, especially into the first, second, and third year of taking care of them. I think we pay less attention to it, but it's a very important detail and that's where our primary providers have to coordinate with the oncologist in taking care of these patients. So to answer, one of the question was about anti-estrogen therapy and causing vaginal dysfunction, hot flashes, and that was one of the question I wanted to cover here. Next slide. The other effects, which fatigue is very, very common. I would say more than 30% actually complain of fatigue. And again, make sure that there are no other reasons other than blaming it on chemotherapy as part of the contributing issue. And depression, psychological dysfunction, anxiety, sleep disorders also contribute to significant amount of fatigue in these patients. We are in the world of anti-estrogen therapy for breast cancer. So because it is anti-estrogen, screen them heavily for osteoporosis. I do screen them with DEXA scans approximately every 2 years while they're on therapy. And when we see a change in the bone density, we either give them bisphosphonates, or we, depending on their risk profile, or we change it into something which is less toxic, like tamoxifen has less osteoporotic effects compared to an aromatase inhibitor. Okay, next slide. So overall, I would say that it's good news. Breast cancer patients are living longer, but they have improved survival now. The bad news is that, yes, we are going to see some of these long-term side effects related to the treatment. And breast cancers are really one among the highest in terms of percentage of female survivors with cancer. So paying attention to these long-term effects and coordinating care with the primary care will become very, very important in management of these patients. Next slide. So I'm going to switch gears from breast cancer to another cancer which we take care in. This is Hodgkin's lymphoma. The good news about Hodgkin's lymphoma is 90% of patients are cured of this disease with just chemotherapy or chemotherapy with radiation. And the early stage they are, the higher the chances of cure is. So we tend to see a very small percentage of these patients coming back with relapsed disease. And again, as I said, I feel old in being an oncologist when I see relapses in Hodgkin's lymphoma, which is one of the best lymphomas to care for. But the problem with Hodgkin's lymphoma is the treatments definitely have changed over a period of time. Previously, it was all radiation, pan radiation, mantle radiation, which is like radiation of the chest wall and the nodes in the neck, and or in vitro Y, which is radiation of the abdominal lymph nodes. And these carried a lot more comorbidities. So we are seeing some of those late secondary stage, secondary cancers in those survivors of Hodgkin's. But lately, we are using more of immunotherapy and chemotherapy. So we may not see mantle cell radiation as becoming an issue moving forward in these patients. So we worry about relapses in these patients very early on. So the first 5 years is a strict follow-up on these. But after the first 5 years of call, you can pretty much say they're cured of Hodgkin's lymphoma, but you have to watch for these second cancers. So one of the questions I posed is in patients who have Hodgkin's lymphoma, if they receive mantle cell radiation, they're at higher risk of developing breast cancer. So that's what we need to remember, especially with mantle radiation. And this is always a board question they like to ask. So the next slide. So honestly, if you move from Hodgkin's lymphoma to a non-Hodgkin's lymphoma, the guidelines are very clear on a Hodgkin's lymphoma patient of what to do, when to do, and how long you want to kind of follow them. But they're very really less defined in a non-Hodgkin's lymphoma patient. So these are the patients, because non-Hodgkin's lymphoma, there are different varieties. There are almost 15 to 16 different subtypes of non-Hodgkin's lymphomas. The cure rates in some, the long-term remission rates in the others are completely different. So because of that, we just don't have any uniform guidelines. So we worry about these patients relapsing in, again, the simplest way, the 5 years. But again, for low-grade non-Hodgkin's lymphomas, these are the patients who can relapse anywhere from 5 to 30 years. And honestly, it's hard to monitor these patients. We just don't know when they relapse in their lifetime. So and that is where it gets a little bit of a burden for the oncologist to care for these for the next 30 years when expecting some relapses. And fortunately, those relapses are small. And these survivors also are at risk of congestive heart failure, stroke, or just because we heavily use anthracyclines, the doxorubicins, in the management of these patients. We also use a lot of radiation. Now, both Hodgkin's and non-Hodgkin's can be transplant patients. So we have another whole risk factors associated with these patients moving on to a transplant. Next slide. So for patients who have finally gone from the stage of just chemotherapy, this includes both your leukemia patients, your lymphoma patients, and moving on to getting a bone marrow transplant. This can be a cure in most of the cancers. But the problem is that because it is a cure potential, they can be associated with long-term toxicities from their high-dose intensive chemotherapy. So for those who do not know much about bone marrow transplant, they essentially wipe the bone marrow clean by giving toxic chemotherapies or radiation, and then they insert back your collected stem cells from a donor or from yourself back into your system. So this whole change, your body undergoes like that transformation. You watch it in the movies, right? I mean, they come out with a different character, but here the patient stays the same. Unfortunately, the bone marrow is a different character. So they have effects because of the donor's marrow. They have effects from their own stem cells reacting, rejecting. So we have to learn to manage those in the acute setting, but in the long term, they have something called chronic graft versus host disease, where the donor cells start activating and creating new problems in the host. And so management of these complications. Luckily, I'm not a transplanter, so I can just always push these patients back to a transplanter to manage. All right, next slide. So long term, again, as I said, we have to watch them for secondary cancers. Now, because this is highly, highly toxic therapies, you have to watch for myelodysplasia, or second leukemias are also very common in these patients. So, getting that blood work done, and also any kind of skin diseases or long-term colitis, psychological distress, all those have to be screened in these patients. Next slide. So a word about immunotherapy. I'm just going to change gears here. So this is like the in thing of what we do in oncology now. And this is just a cartoon to explain what happens with your immune system. I mean, you have something called B cells and T cells. B cells are essential for us to fight the bacterial infections, and T cells are the ones which decide about the viral infections and plus the overall immunity and our immune defenses for any kind of attack we have from any of the cytotoxic cancer cells. So when you have what we call as antigens from the cancer cells presenting to our own immune system, there is a highly activation of different molecules, interferons, IL-2s, TNFs, and also something called HLA complex. All this activates our T cells to understand why these cells are foreign and how we can kill these cells. So in the layman's term, there is helper cells and they're activated cytotoxic T cells. So there's always a crosstalk between the different types of these T cells to bring about the cytotoxic T cells. So the cytotoxic T cells are the ones which are actually important in causing the cancer kill. But these cytotoxic cells also, once they're done with their job, they are good part of that is that they have some kind of a retained memory where they can go in and keep that memory intact. So when there is another cell, which is the same cancer cell coming in, the memory cells again activate the cytotoxic T cells and go back into that function. So that's the beauty of our immune system. Honestly, the more you read about this, the more, you really cry about how good our body is, and we take it for granted. So, but this is what happens on the biology of the oncology for cancer patients. Next slide. So what we are really looking at it is there are different forms of this immunotherapy. So the basic and the very basic concept of this is you're just using your own immune system to fight against your own cancer cells. So these are something like checkpoint inhibitors. That's the name we are going to use. And big thing into now breast cancer and CAR T cells, where you're basically manufacturing these T cells in a lab and giving back to the patient to fight their cancer. And then also the vaccines, which have been in and around for a very long time in these advanced cancers. It's amazing some of the, like I had a patient started with lymphoma, had a patient go through CAR T cells of his programmed T cells, and honestly, a cauliflower-like tumor was completely gone, and basically no evidence of disease on the PET scan. So it's amazing how these therapies work, but every time you get something benefited so high, you come with a price. The price is about the toxicity too. So the difference is that chemotherapy kills cancer cells and the normal cells, but immune system is more on a different level of attacking the tumor cells. The price we pay is the overactivation of our own immune system in developing autoimmune problems. Next slide. So this is just a cartoon to help you understand what really goes on a tumor cell versus a T cell. So the T cell is what our cells are, and they have receptors which are called as program-derived cells, PD-1. The PD-L1, which is program-derived lymphocytes, are what the tumor cells are expressing as a receptor. So it is very important that the tumor cell deactivates the PD-1, which is on the T cells, and also the T cell receptor. So there is no crosstalk on the T cell. So the tumor cells they proliferate because they're inhibiting the component and they're escaping this whole immune system about our T cells, what I explained a few slides ago. So that is the beauty of the tumor cell, that it is able to overcome this. Now we have become outsmarted. We have outsmarted the tumor cells now that we have drugs which actually block this PD-1 and the PD-L1. So PD-L1 on the tumor cells and the PD-1 on the T cells. And because of this blockade, there is excessive amount of tumor cell death. So they are no longer able to escape that immune system what we have. So the programmed T cells are able to achieve their cell kill on the cancer cells. So this is the very simplest way, but it is a lot more into these therapies. But these are now moving ahead. And the one drug which is called Keytruda or pembrolizumab is almost has 26 indications in cancer now. So different tumors. It's the same basic mechanism of attacking these PD-1 and PD-L1 therapies. Next slide. So because we have such robust responses, obviously we have to know what complications they have with immunotherapy. So because it's overactivation of immune system, just understand it's like an autoimmune disorders, like your rheumatoid arthritis, Sjogren's, or, where, you have different effects, like it can cause, the big things are like colitis, which is excessive amount of diarrhea, rash, and pneumonias. They can cause something just mimic like a bacterial pneumonia, like pneumonitis. They can cause abnormalities in your liver function, and they can affect a lot of your endocrine organs, including pituitary, including thyroid, adrenal gland, and as a result, you have various endocrine effects. So it can mimic a lot of your hypothyroidism, like your thyroid disorders or your diabetes, and it's important to affect. I had one patient who developed myocarditis with this one of the therapies, and recognizing myocarditis is important. And again, obviously, that is a very serious effect of this immunotherapy. Next slide. So I think, unfortunately, I have to say that a lot of oncologists also fail to recognize some of these side effects, and being very educated about and taking these problems seriously, especially when they are in the early stage, is so important. Because diarrhea can be a simple thing. Okay, you can say, oh, well, if you're on chemo, you can get, everybody gets diarrhea on chemo, right? But if once they develop that colitis, which is diffuse inflammation, similar to like your ulcerative colitis or Crohn's disease, patients can die from this serious complication. They can develop bowel obstructions, they can get perforations, and it's not easy to go and operate on these patients. So if you can snip these effects very early on, I think recognition, education is so important. And once a patient develops these grade 4 toxicities, especially like colitis, you cannot use these immunotherapies again. So any patient who gets hospitalized for these side effects, you cannot reintroduce immunotherapy. That's the important. That was one of the questions I asked, whether we can dose. There's nothing like dose reduction. You stop. That's it. And even unfortunately, some of these patients are somebody who have complete response to treatment. They will cry and moan about it, saying that, hey, I do not want to go off this therapy. But right now, as we speak, we do not have a way to work around these immunoside effects. That's why recognition early on, especially if you're having that response, is very important. The other thing to understand is primary care also has to be educated that, hey, these are new drugs. So if they pay attention or have just basically educate themselves a little more on what is my patient getting and understanding, sometimes we may not even see these patients. So what we do in our practice, in my practice especially, I have a nurse practitioner who alternates with me in terms of seeing and screening these patients. So that way, if there is any, and of course, we talk a lot to the patient. So if they call us with diarrhea, we take them seriously about starting hydration, starting steroids early on. And the same thing applies to pneumonias. Next slide. So that's what is the communication is the key, and it is a very, very coordinated effect. And these are not easy drugs. These are difficult drugs, even though they have amazing responses. So a very coordinated effect between an oncologist, a patient, an oncology nurse, a pharmacist and also the primary care provider is extremely, extremely important in managing these patients. Next slide. So now I'm going to switch to something called lung cancer. So we all know this has been we all know the treatments in lung cancer includes either it's radiation or radiation chemo combined, or surgery in the very early stages. So if you have surgery in the very early stage, the complications from surgery become your long-term complications, because some of these patients are essentially cured in their stage 1 lung cancer when you have resected the tumor. To offset some of the surgical option, now we are using something called stereotactic radiation therapy, or CyberKnife, and it definitely has less comorbid status compared to your surgical resection of opening up your chest and all that. But it is as good as surgery in patients who are poor risk for surgery, so that we have some kind of an alternative management there. So, and again, once patients go through surgery, you still have to, a majority of these patients end up receiving some form of adjuvant therapy to improve their, and the adjuvant trials there was one major trial which showed overall improvement in survival. So most of these patients end up getting chemotherapy. Next slide. Now, for those patients who come in with more advanced, which includes your bulk of your patients, so these are your stage 3, stage 4 patients, you're really talking about palliation of their symptoms, or you're really talking about getting them through to give their sustained overall survival benefit. So these are lot more toxic treatments, including a combination of both radiation, chemotherapy, and some of these patients do also get surgery as part of their treatment. So because of this, they live longer. As I said, immunotherapy has made a huge difference. Targeted therapy, especially in the field of lung cancer, we have now about 9 targets where we can hit with pills. These are patients who are not even on systemic therapy, but they're just taking oral therapy and still have a fair share of side effects such as rash, diarrhea, some of these endocrine side effects. But the good news is they're living longer. The good news is even those patients who have a particular target with stage 4 brain mets, we are seeing years of their life. So I'm sure 5-10 years from here, we are going to see a lot more different type of side effects from these therapies. Next slide. So in a long-term management of these lung cancer survivors, where I'm now seeing a lot more of these, again, fatigue, dyspnea, psychosocial distress, and also seeing the chronic pain syndrome. And unfortunately, there is a lot of drug dependency which goes on in these patients. So initially, you're giving them the acute side effect treatment management with narcotics, but at least 50% of these patients pretty much end up being narcotic dependents. I think going through that pain management scale and also having that called behavioral sessions, it really helps them to get them off that narcotics dosing schedule. But we try hard on these patients. So again, watching for side effects on immunotherapy. Next slide. Testicular cancer. I included this because this is like your Hodgkin's lymphoma counterpart. So here we use a lot of these cisplatin-based therapies. That is one of the drug which is has amazing response rates. And again, like Hodgkin's lymphoma, testicular cancer also has more than 90% response rate and long-term cure. So it's important that you hit them harder. Unfortunately, most of these are men who are of a younger age, especially with germ cell tumors, which are, the older patients, you see seminomas, which is a little differently handled than younger patients who have their germ cell tumors. So we see a lot of these having a cumulative burden of morbidity because we are giving them such high doses of therapy, especially associated with cisplatin. They can have, we also use a lot of, idarimycin-based regimens. So we see cardiovascular risk toxicities, and also metabolic syndromes, which include your endocrinopathies based on what we treat for long-term testicular cancer survivors. Next slide. So the big thing we talk about is what we call as bleomycin long. Bleomycin is one of the major drugs we use as part of the BEP regimen. And patients who are smokers have more toxicity in their lung. And once you get bleomycin toxicity, if you do not recognize these patients having a lung injury, you can result in permanent lung fibrosis, which is a very, very devastating complication for somebody who's very young. So screening these patients upfront using pulmonary function tests is extremely important, and also educating them about what not to do to make sure they don't get bleomycin lung is so important. Then it again, quitting smoking is the most important thing. Next slide. So how long do we manage these patients with testicular cancer? And that was one of the questions I threw in there, because they can develop these long-term side effects related to nerve damage, hearing loss, as well as development of secondary tumors because they have survived chemotherapy for so long. Next slide. So we do have to check their blood again. Follow-up is lifelong for these patients, and we oncologists can't afford to take care of them more than 10 years. So there is a shared burden between the primary care and us, but we intermittently do see these patients back because they do suffer from long-term hematological problems where they can develop myelodysplasia or chronic sexual dysfunction, infertility issues, psychological stress issue, depression, and these are all extremely common. So the follow-up for testing, especially for those patients with germ cell tumors, the follow-up is lifelong. Next slide. Again, we have to just have a very coordinated care with the primary care. So because 5 to 10 years is where we can draw a line, especially now because we are seeing so many survivors. I think it gets to that burden point for an oncologist to carry the burden for more than 10 years. So I think having I think it's better we don't duplicate our work. So we just have to have that nice survivorship plan carried over with the primary care provider. Next slide. One slide or one or two slides about what we do with head and neck cancers. These are difficult cancers to deal with because it involves your mouth, the entryway for your eating and drinking, as well as speech. So that is the reason that any treatments you involve with these head and neck cancer patients just becomes complex because of their quality of life from any of these treatments. So most of these patients end up getting radiation. We are using less and less of surgery now. Previously, it used to be removal of the tongue, removal of all the lymph nodes in the neck, or sometimes the voice box, giving them a permanent tube in the neck, which is called a tracheostomy. All those used to inhibit and impinge on their quality of life. But now we are using more and more chemotherapy in combination with radiation therapy to spare them from relatively the surgery part of it. So as a result, they suffer from dry mouth. 60% of the patients with head and neck cancers do suffer from dry mouth. Now you can understand whether chemotherapy is causing it or radiation. I think majority of the effect comes from radiation. And they also suffer from dental complications like dental caries and loss of teeth and, again, non-healing of the bone when they have the extractions. That is basically called osteoradionecrosis. Next slide. And also they suffer from psychological issues, nephrotoxicity. And the other thing is I had a singer who had head and neck cancer, and he had laryngeal cancer. And his biggest issue was he used to sing in South Point. And he said, there's no way, we have to work around the treatments, but there was no way he was giving up his employment over it because he couldn't sing after the treatment. So that was one of the most difficult consultations I had as to, any therapy is going to cause him dry mouth and that will impair his ability to sing. So we had to get speech therapy involved right up front, and also had modified his what we call as IMRT to really precisely give radiation to his neck so that he has very minimal radiation side effects and he could still go back to his employment. And honestly, it's been 6 months, we finished treatment, and he's really doing well, and he still continues to sing. So those are all the things we have to work with these patients. Next slide. So there's honestly, anytime I say when you're a cancer survivor, the day you get diagnosed with cancer is when I think your survivorship really stands. So it is very important what you do in the acute to say what you do in the chronic. So I think if you don't take care of them in the acute setting, you're really not going to correct much when you go into the chronic setting. So I think starting it on day one is so important of how you educate these patients to prevent any of these complications. So it is a little disappointing because we really do not have best practices in caring of these patients, because there is just a multitude of treatment options we have. I mean, as just as the way I described, between chemotherapy, immunotherapy, targeted therapy. So just that gives so much of variety here that you can't have one practice guideline which attributes to everyone. But I do look up to National Coalition for Cancer Survivorship or National Cancer Institute, which have laid out some templates for management of these patients. Next slide. So I think it's so important that we screen them for blood clots, we screen them for pain syndrome, we screen them for sleep disorders. Hair loss is a major problem in women because they say that it was related to the chemotherapy. The risk of permanent alopecia is extremely small, less than 5%, but they still have issues related to their hair growth. So fertility issues, especially in younger men and women, and also living healthy after the cancer becomes so important for these cancer survivors. So that's where we really need help from nurse practitioners or some social workers or other ancillary organizations. And NCC is big into cancer survivorship, and we are rolling out these. And I've been part of the Thrive Nevada board too, and hopefully we will make some difference as we move along in the future. Next slide. So again, I cannot re-emphasize that it has to be a coordinated effort. It cannot be a burden of either just the surgeon, the radiation oncologist, or the oncologist. I think all providers involved in that a patient is extremely important in helping them transition from their acute effects to their chronic care, and having this multidisciplinary approach. Tumor boards, meetings, all these especially are important. I think a lot of insurances now are emphasizing that we have to have a survivorship care plan, and we have a comprehensive cancer centers has enrolled ourselves into some of these survivorship care plans. So it's something like the MIPS and coordinated oncology care, and I think it's very important that you have that roadmap. You talk about palliation, you talk about palliative care, you talk about hospice options, you talk about long-term treatment, pain complications, pain management, and all of those issues in that survivorship plan. And also when to get screened, when to get these procedures done is all part of that plan. So I do look up to American Cancer Society for those templates. Next slide. These are some of the resources you guys can tap in, especially like breast cancer guidelines, ASCO, which is American Society of Clinical Oncology, beautiful templates for some of the survivorship care plans. The same thing is with NCCN. They have extensive material for patients for survivorship. And also, I also look into Cancer Care Ontario. We do really rely more on the ASCO and then the NCCN guidelines for care. Next slide. So with that, I will end, and hopefully I was able to cover a lot more topics, but it's extensive. Thank you. If you guys have any questions for me.
Yeah, any questions for Dr. Thumala, please feel free to unmute yourself or write into the chat box. Okay, looks like your presentation was really good, Dr. Thumala. No questions at all.
Whether it was good or I confused everyone.
Oh, it's very good. Thank you.
Yeah. So do you want to do the poll questions now, or do you want to, does anybody have a case that they would like to discuss with our team? No cases today? No worries. Dr. Thumala, do you want to go over the questions and give them some answers to the questions?
All right, so pull up the questions again for me, please.
Can you guys see this?
Yeah. So the first one was, I think majority picked 5 to 10% on the risk of cardiac toxicity. You got it on the mark, so I'm happy. At least more than half of it answered correctly. Yes, as I said, it's about 6 to 11%, but those patients who are older than 75, if you do a combination of both your adriamycin, pertuzumab, especially for HER2 therapies, it gets to almost about 20%. So you have to be very careful in those patients. Now, the second question was about long-term use of anti-estrogen therapy in the treatment of hormone-positive cancer patients, of what effects it can cause. Yes, loss of bone density is a major problem. That's why screening these patients for osteoporosis is extremely important. I do DEXA scans every 2 years. I do a baseline and I do it every 2 years. And as and when there is a bone loss, you have to intervene early on because your therapies have good benefits, but you cannot have a broken bone or a hip. Good, I'm happy. Most of them got that question correct. Then the risk of second cancers, which are solid tumors or any form of hematological malignancies in mantle cell radiation, post-treatment. Again, this should have been breast cancer, which is more seen with mantle cell radiation therapy than the Hodgkin's lymphoma. The fourth one is the question on immunotherapy. I didn't expect anyone would answer this question, but again, for somebody who's developing severe colitis requiring hospitalization is a grade 4 toxicity on immunotherapy. And these patients, we have to discontinue immunotherapy permanently. You cannot re-challenge them unless there is other reason for a diarrhea causing, but most often if you get that severe complication, you cannot continue. So everybody got that wrong. I'm sorry. Then the fifth question is about head and neck cancer patients who are treated with cisplatin or radiation, and after 2 years developing dental caries and chronic dry mouth. So also I put in there that the patient was unable to hear or understand most of your questions. So remember, there are three talks. You're talking about dental caries, and you're talking about chronic xerostomia, and you're talking about ototoxicity. So it's just a combination of both the cisplatin and radiation therapy we use, which is the cisplatin, the fourth answer. So I know most of them picked radiation thinking only about the dry mouth, the caries, but remember the patient couldn't even hear. So that is an ototoxicity related to cisplatin therapy. So that's just a combination treatment. Okay. The last one is about long-term survivors of Hodgkin's lymphoma transplant. And how long should there be the follow-up? And as I said, the follow-up has to be lifetime, and I'm glad a lot of them got that answer correctly. Yes, it is because we have to watch them for secondary cancers, leukemias, lymphomas, and the relapses from lymphoma or secondary cancers such as myelodysplasia or acute leukemia. Very good. So I hope I educated you all enough.